Our next speaker is Dr. Randall Brand. He's from the University of Pittsburgh. He's a professor of medicine. He has an interest in genetics and hereditary components of both pancreatic cancer and cystic lesions of the pancreas. He has been a funded investigator and has been a large contributor to the Early Detection Research Network. Today he's going to be talking to us about genes and how this affects our analysis and how we think about pancreatic disease in the context of genetic inherited disorders. Please welcome Dr. Brand. Which one is yours?
Thank you, Dr. Hines. I really want to thank Aggie and Dr. Go as well for the kind invitation to speak at the symposium. I'm just going to take a second. I know I'm the last talk before lunch, which is always dangerous. I also know I'm at the end of the morning session, which I'm used to as a gastroenterologist. But I don't know if you guys, everyone in the audience really appreciates how lucky you are to have the Hirschberg Foundation. It's very, we're you know, those of us in Pittsburgh, even though you take all of our young superstar surgeons after we've trained them up, they come here because you really are. One of the reasons why I went to Pittsburgh, because we wanted to study the disease in a multidisciplinary manner. And they come to UCLA and talking to John and Mark, they have the same environment here. I think in part, a lot of the infrastructure you have added advantages because you have the Hirschberg Foundation. But what's nice about the Hirschberg Foundation is that we even get benefits of it in Pittsburgh and across the country. And I think that's the vision of the leaders of the Hirschberg Foundation, that we've learned very early on, and one of the reasons why Dr. Reber and Dr. Go started the APA was that we have to work together. And all these new grants that are coming out are consortium grants. And I think the Hirschberg Foundation early on recognized the importance of getting physicians anywhere in the country involved. We have to get the young faculty involved. And we have a young PhD who's studying now the interactions between the nerves and the tumors that was awarded a Hirschberg grant as well. And we're hoping that now, that'll lead her, because you need to get that grant to get a good faculty position. We're hoping we can use that to drive her to have a faculty position, so yet Pittsburgh will benefit and have another person fighting this terrible disease. So let me just thank you. So now the topic that I get to talk about is pancreatic cancer. Is it all in the genes? And I just want to disclose that some of my research I'll be presenting to you was funded by some commercial laboratories who gave us free genetic testing, but it really doesn't conflict with the content of the program, and I have no financial benefits. So I'm going to give you a general overview, sort of what I call genetics primer for those of you who fell asleep during your biology classes. We'll do some defining of what we mean by hereditary pancreatic cancer. Some of this was already discussed by Dr. Maitra's superb talk. Little bit about pancreatic cancer surveillance, and then I'm going to review who are the candidates for genetic assessment, and then how you incorporate that into clinical practice. So you've heard the numbers before, so I won't go through that. And just keep in mind that there's about an average lifetime risk of about 1.5% for getting pancreatic cancer. And like the other talks, I'm really going to be talking about adenocarcinomas today. Again, you saw this curve earlier. About 10% are from what we call hereditary syndromes, or where we sort of know the genes that are involved. When we mean familial, there seems to be too many cases in the family, whether it's even just having one parent increases your risk. But we don't know necessarily the genetic etiology. That's separate than, we have a lot of bad terms that overlap. Familial pancreatic cancer, which I'll redefine during the talk. So let's start with what is genetics. It's the branch of biology that studies hereditary and variation in organisms. It's how traits are passed down through families and why we're all different. In the nucleus, we have chromosomes, and there's humans have 46 chromosomes divided in 23 pairs. Of course, 22 of them are the same for everyone. Then we have our sex-linked chromosomes. And females have 2 X chromosomes, and men have an X and a Y. So each chromosome contains genes, and these genes are made up of DNA, and it's these genes that then get transcribed and turned into proteins, and they help our body function properly. So we get a mutation, and we're trying to get away from that term mutation, but it's still commonly used to, or what we call pathogenic variants, and that's where there's been a change in that code, that our body now doesn't process it correctly, so it either makes it stop or makes a protein that doesn't work. And that's what we're calling a mutation. Now, it's confusing because you hear us talk about mutations in the tumor, and Dr. Matra had this showed you the picture of the tumor with all the different mutations that occur on it, and how KRAS is like the most dominant one. Those are acquired mutations. Those aren't inherited or germline that you can pass on to children. There is a small subset, though, and those are the ones that occur in the germline that you can pass on, and that's going to be the focus of the talk today. And keep in mind that as everyone sits here, each person has 2 million differences in your DNA to the person next to you. But most of these changes occur in our chromosomes where it doesn't impact on the makeup of the protein. And you can have changes where you get the same protein still. You have changes where the substitution in that protein of an amino acid, which makes up these proteins, doesn't change the function. So we're fortunate that most of us have the ability to tolerate all this change that occurs. The ones that we worry about are those where they affect the function of the protein. And this is important because when you get genetic test results back, it's up to the laboratories to determine whether these changes have any clinical significance, and it can be tough. And you'll see that when we talk about genetic testing results. So just as we have 2 copies of each chromosome, we also have 2 copies of each gene. We get 1 copy from mom, 1 copy from dad. And if the gene has a mutation, this is passed down through the families. And there's the common Mendelian inheritance pattern, which is the easiest, and what we'll discuss today is that they're inherited in 2 different ways. What we call an autosomal dominant inheritance, where a person has 1 working copy of the gene and 1 non-working copy of the gene, and they have a 50-50 chance of passing the non-working copy to the child, and having that 1 copy alone puts them at significant risk. And so how that works is, if you see the white here, that's a bad copy of the gene, and then there's 3 good copies that if you pass it on all the different combinations, there's a 50% chance that 2 of those will go. Now that's contrasted to autosomal recessive inheritance. And that's where you need 2 copies of the gene to not work. And a common disorder for that is like cystic fibrosis. You have a 1 in 4 or 25% chance of having that. And this is just a little figure again showing that. But it's usually not that simple in real life. It's usually genes and diseases are not caused by just 1 single gene. They're caused by gene to gene and gene to environment interactions. And that's why we sort of use this wastebasket term of multifactorial. And it can lead to birth defects, diabetes, and cancer. Now, I can do my work in my office without my genetic counselors, because when patients come to see us, we go through and we educate them about why we're testing their genes and what it means. And these genetic counselors, I have 2 of them, that are part of the healthcare team. They spend the time going through all of the different issues involved with it. And so it's critical that if you're going to undergo genetic testing, that at least you have an experienced healthcare provider that is able to either do the counseling himself or has that as a tool. The other thing that they do, which is incredible and time-consuming, is facilitate getting the test paid for. It's not that we have to work the system in a way, because you have to be sure each insurance company has different requirements, and I'm telling you, 25-50% of their time is spent trying to figure out how to get this through so it's not a financial burden to the patient. And what one thing that the genetic counselor does is they obtain a pedigree, or what we call a family history. And this allows us to look to see if there's patterns to help us decide to do what genes to test for. And this is an example, and Anirban brought that up, of a family tree with lots of pancreatic cancer. As he said, all three of the siblings and both parents dying of pancreatic cancer in President Carter's. And you could add it in there with President Carter now having a melanoma. So there are known hereditary syndromes, and several were alluded to, and I'll go through that in a minute, that have an increased risk for developing pancreatic cancer. And then there's this condition called familial pancreatic cancer, where you at least have 2 cases of pancreatic cancer that are directly related to each other. So it's either a parent-child or 2 siblings. And so that's what we mean by familial pancreatic cancer. This is just a list of some of those syndromes, and you can see the risk compared to the general population developing pancreatic cancer. And again, this is the sort of the population that we talk about considering doing pancreatic cancer surveillance for, which is why it's important to identify whether you carry these mutations. Now, when Johns Hopkins looked at their data now keep in mind, when we're talking about the number of relatives, so first-degree relative means that you're directly related to them, so parent, child, or sibling. These are all from families that met criteria for familial pancreatic cancer, because I know a lot of you have been touched by pancreatic cancer. Usually it's just fortunately one relative, so that doesn't mean when you see one first-degree relative that you have a 7-fold increased risk, which keep in mind, odds are you're, even with a 7-fold increased risk, I told you the lifetime risk was 1.5%. That's over an 85% chance that you're not going to die of pancreatic cancer, but this is in a familial kindred. But this shows you that there is increased risk with having a couple family members affected with pancreatic cancer, which is why we counsel these patients as well for surveillance, and they're also good candidates for doing testing, genetic testing on. So, can we screen for pancreatic cancer? And just to give you a little comment about it, I know this was briefly touched upon this morning. If you think about the goal of screening is to decrease the risk of dying from that cancer. So it doesn't mean that you're not, I always tell my patients when they're undergoing colonoscopies that if I find a colon cancer, it doesn't mean that colonoscopy was bad. It was good because you were asymptomatic. You have a better chance of being cured from it. It's even better when I find an advanced polyp because we prevented them getting the cancer. And so less people die after if you do 100,000 colonoscopies on 50-year-olds and compare it to 100,000 50-year-olds who never had a colonoscopy, less people die of colon cancer. That's a successful screening test. As was alluded to earlier, we don't have that test right now for pancreas cancer, but we're working on it. You have to be cautious, though, because there's also indolent diseases. And being a man, I'm particularly conscious of that because it has to do with prostate cancer. In particular, a lot of us will die with prostate cancer. It will never bother us through our life, and the cure can be worse than the disease. So you have to be careful. There's also another thing called lead time bias, which I'll describe to you in a moment, that we have to always keep in mind with cancer screening. It's also not useful to have a screening test if we find it at a stage that we can't cure it. And then we need, as was alluded to earlier also, the test must be acceptable to the patients and primary care physicians. So what do I mean by lead time bias? Say you're diagnosed with pancreatic cancer at the age of 65 and you die at 67. That was 2 years. But you go into an early detection program and we actually diagnosed you at 62, but you died at 67. It looks like you had you lived 5 years with that disease. But in reality, you would have died at the same time if we had waited till you got symptomatic. Really what we want is for you to die of an MI at 85. Then I think we have a truly successful stage. And I think now I'm more optimistic than ever with our improvements in our treatments. If we can get patients to the OR when it's still resectable and they can get their preoperative and postoperative treatments, that we will be able to give these patients long-term survival. So today, when we talk about pancreatic cancer, we're not talking about screening. We're not doing testing in the setting of the asymptomatic general population. When we talk to people for pancreatic cancer screening, we're actually mean surveillance. The terms will be interchangeable for the rest of this talk, but keep in mind, we're only testing in an asymptomatic high-risk group. Diagnostic is when someone comes to me and they may already be jaundiced, turned yellow, or have pain. Then we're doing the test to try to figure out why they have those symptoms. And that's too late. We know that because that's the way we've been doing it up until recently. So what's our target? And the reason why this is important, because we have to incorporate this into counseling our patients for genetic testing, is I think finding a tumor at an early stage. In the long term, with improvements in molecular diagnoses and imaging, we hope to get it at those precursor lesions that were shown earlier, these PANN3 lesions or these cystic lesions that have high malignant potential. So back in 2007, with expert opinion, we put together some general guidelines on who we thought should undergo surveillance. And as you can see, it's pretty much hereditary at this point. People are trying to explore the new onset diabetics to see if we can identify a subset of those patients. And what we're talking about, if you remember Dr. Matra's nice sieve diagram, is we're at that bottom now. We're at that doing the more invasive, expensive study with these patients because their risk is great enough. They've made it through a couple sieves just based on their family history or genetic makeup. So just to summarize this portion of the talk, surveillance is limited to high-risk patients. That's right now is hereditary syndromes accompanied or associated with an increased risk of developing pancreatic cancer, or members of familial pancreatic cancer kindreds. We have to always be aware that there's no data at this time demonstrating that surveillance of pancreatic cancer decreases the risk of dying from this disease. I could tell you that internationally we've tried to put together all of our surveillance detected pancreatic cancers, and you're sitting at under 200 cancers. So it's not a large number that are found in this way. At our site, though, where we picked it up, over 80% of our patients are at least found at a resectable stage, and that's compared to the average patients where it's about 35%. So this should translate into a survival advantage, particularly as on parallel, our oncology colleagues are improving treatments. And we favor endoscopic ultrasound as our imaging, but MRIs have also been found to be acceptable as well. I just want to give you one case of pancreatic cancer surveillance, just to show you an example. This is a very nice family. I took care of them when I first came to Pittsburgh. This woman here heard that I specialized in hereditary pancreatic cancer, and she came to tell me that her mother had died of both, had colon cancer at 70, died of pancreatic cancer at 96. Her aunt died of pancreatic cancer at 80. Another aunt died of pancreatic cancer at 53. So she was worried. And so I talked to her about screening and all its limitations. And when we were getting her history, she said, and then my sister here was just found to have large cysts. And Dr. Matra told you about this. And they told her, just come back in a year and get an imaging test. And I said, hold on a second. I think I really need to see your sister even more so than yourself. So the sister came to see me. I did an endoscopic ultrasound on her, and indeed she had a cyst. Back then, we were operating on cysts in the familial setting when we thought it was a precancerous cyst. She actually had a couple of them. So we thought it was one of those IPMNs, and it was over 2 centimeters. And so we suggested she get an operation, but this is the real world. She decided she wanted to move back to Chicago. Her daughter wanted her to move back because that's where her daughter lived, so she could help take care of her. There was a 6-month delay for her going to the operating room, and when they took her to the operating room, they opened her up. Her cancer was spread throughout her abdomen, so they couldn't do the operation. And so they had to close her up, and unfortunately, she passed away. So that prompted the youngest sister of the group to come see me. And so she came and saw me, And I did an endoscopic ultrasound. This just shows you that we have these special scopes that have ultrasound probes on the end, and we have the capabilities of putting a needle through it and biopsying them. And I did an endoscopic ultrasound, and I found this cyst in her head of her pancreas. Now, what am I going to tell her? The rest of her pancreas looked fine, including her body. I just heard about her sister. We really recommended that we do a Whipple procedure on her. And she said, look, I'm almost 80 years old. She was 77, 78. Unless you can show me something more definitive, I don't want to be operated on. I said, all right, well, then I'm going to have to follow you closely. So I brought her back, and in June, she actually developed a nodule. But she was a lot smarter than I actually was, because this nodule wasn't in the head of the pancreas. It was elsewhere in the pancreas, in the body, which wouldn't have been removed if we had done the operation on her. And right now, it was about 7 millimeters in size. So I said to her, I have the ability, and you can see, it's hard to see, that's actually a needle going in there and biopsying it by endoscopic ultrasound. But at this point, we were only getting atypical cells. And you know what she's going to say to me? It's like, no, unless you can show me it's cancer, I'm not going to be operated on. Because at this point now, we're telling her, you got to take out your whole pancreas. And she came back in September. I didn't show an intervening MRI that we had done that did not show this nodule in August, because like I said, I can't sit here and do endoscopic ultrasounds on you every 3 months. And this time, though, we were able to document its cancer. And the reason why I show this to you is that the cancer was 1 centimeter in size, and she is now out over 6 years, alive, cancer-free. So with her whole pancreas taken out as well. So she requires an insulin pump, but her life is normal. I see her. I'm sure John and Mark may have seen her in clinic as well, because she followed up with some of our surgical colleagues, and she's doing great. So now, who are candidates for genetic referral? So it was funny, back in 2000, the Human Genome Project was first draft of it came out, and we all thought that this was going to be it, that this would take care of all of medical disease, and boy, did we learn that this just opened up a whole Pandora's box. So when you talk about genetic testing, there's a lot of ethical questions, legal situations, privacy concerns. I can assure you now with GINA, you're not allowed to have genetic information used to discriminate against getting insurance. That's different that's for health insurance, though. That's not necessarily for life insurance. So when you go to see and undergo genetic testing, there's actually 3 different results that you can get, and this is important to understand. So if you have a positive result, that means that you're at increased risk for whatever that is associated with that cancer, with that gene, and the cancer is associated with it. You'd be a candidate for screening, and you may want, and we recommend that you test other relatives so we can see who else carries it. If you have a negative result, that typically means that you don't have those same increased risks, you don't require intensive surveillance. And then we have this third condition, which is the hardest for patients to understand, but is actually the most common result after a negative. It's more common than a positive result, and that's these variant of uncertain significance. And what it is, it goes back to one of those changes that we can't tell whether or not it actually changes the function of the protein. And they have a bunch of all the commercial laboratories and university laboratories have all these criteria that they try to apply to it. But even with that, they just tell you at this point, we don't know. And so we can't make medical decisions, so we don't offer testing on it. And we just have to treat the patient as if we don't know their genetic risk. These variants of uncertain significance, these VUSs do get reclassified though. And so we do follow that up with patients when they have changed. Sometimes they get reclassified to benign, no effect. Sometimes they get classified to now you need to do something with it, pathogenic. So why undergo genetic risk assessment? Well, a lot of people are wondering, why did I get this cancer? So this can give you a reason. What was alluded to earlier, this could actually provide information for your treatment. Many of those mutations that I showed you on the list and the syndromes involved with it, like the BRCA1 and 2, they're candidates for PARP inhibitors that was mentioned earlier. You may be able to use a checkpoint inhibitor if you had an MSI high tumor associated with Lynch syndrome. And then it's amazing to me when people come here and you're seeing them with pancreatic cancer, almost everyone's concerned about what about my family, my children, my siblings. And so this gives us a chance to address that with them. Now, the con of testing an affected pancreatic cancer patient is that sometimes this gets thrown back to us by the insurance company is what are you going to do with that information? Because finding a BRCA mutation carrying a pancreatic cancer patient, they're worried about their pancreatic cancer. We're not worried about them developing breast cancer if it's a female. But so in that setting, you know, we now at least have the ability to argue back that it could help with their therapy. And there's also the more, if you test for it, you may get these variants of uncertain significance. But I think it's even more important to test family members. You don't need to worry about these VUSs because we only test the pathogenic variants, so those variants that we're concerned about. And if they're found to be a carrier of a mutation, then they can undergo surveillance, prevention. Maybe that'll drive someone to stop smoking. We believe that there'd be candidates for EUS. Expert opinion sort of supports that as well. And just as important, if you don't carry that mutation, then your risk is the same as a general population. So typically, you have a 50-50 chance in most of these syndromes that we're describing. So how do I evaluate patients? We obtain a pedigree, at least 3 generations. We review that pedigree to see if there's any hints about particular syndromes that we're used to. We look for early age onset cancers. And this just shows you, again, that same list of syndromes, but that other cancers are typically seen in them. So FAM, familial atypical multiple mole melanoma, where Dr. Matra showed you the picture of all those moles on the person. Those patients have early age onset melanoma, and pancreatic cancer that tends to be later age. With the BRCA mutations, you get breast and ovarian cancers common. And so all of these are associated with additional cancers. And so then we incorporate that all into this, and really it's important to, in a group that you go to a spot that they can at least guide you to experience places with pancreatic cancer surveillance. And it used to have a very limited role in pancreatic cancer testing. And in part, it's because most insurance companies will give you one shot for genetic testing. And it wasn't until the Supreme Court ruling in 2013 where it said that you can no longer patent genes. So Myriad Genetics used to be the only lab in the US that could do BRCA 1 and 2 testing. And as Dr. Matra suggested and told you, and as I will show you as well, those were the most common in the familial pancreatic cancer patient setting and for pancreatic cancer. So we would test for that, and we'd have difficulty doing all these additional tests. Once that became knocked out of the equation, now we can do panels, and technology improved with next generation sequencing, and we can test a panel of genes. Now it's interesting though, from an insurance standpoint, they won't cover panel testing because they don't know a lot of the a lot of these genes that are on the panels aren't well defined enough to meet their criteria for coverage. But the commercial laboratories, for the most part, will run these panels because it really doesn't change the cost of their test and report them as well, and then they just bill by the individual gene. So there's only one set of guidelines out there that Dr. Singhal and I was part of the committee that did this. It was from the American College of Gastroenterology, and they were at least suggesting testing for BRCA 1 and 2, CDKN2A, which causes FAM, POLB2, and ATM. Now there's additional for, when appropriate, Poitiers and Lynch syndrome. When we wrote these guidelines in 2015, panel testing really was just starting to take off, and I think the next revision will definitely just say do a panel with all these candidate genes. And if you do a panel and you take these people that have excess cases of pancreatic cancer, you start getting a very good yield of almost 15% of these excess cases of pancreatic cancer can be found, almost 20% actually, and are known. Again, That's great. That's for a subset of 5% of pancreatic cancer patients. What I'm more interested in is simplifying the process. And so what we're doing right now, and I give Ambry Genetics, the company, a lot of credit because they're doing the study right, is that with our site, along with Beth Israel, which is in Boston, one of the Harvard hospitals, and Virginia Piper in Arizona, we're taking consecutive patients with newly diagnosed pancreatic cancer and testing them with the panel to see whether or not, what the yield would be, with the premise of two things. One, being able, if we find something, to help the patient with their treatment, and two, again, being able to get valuable information for the family. And so these are just the list of genes that are on this panel that are known to be associated with pancreatic cancer. Now, for technical reasons and for research reasons, they're offering a variety of additional genes as well that they have available that doesn't really change their cost. It's all done on the same chip. And they also do some analyses for Lynch syndrome, which requires some special techniques. So this is going to be presented at our meeting in May. We're up now to over 200 patients, and we actually hope to have the study completed by at least midsummer. We had about 54 patients who actually met criteria if we saw them in clinic for undergoing genetic testing, which means that we offered it to 84 or 74 additional patients who wouldn't have gotten the testing. And 4 patients met that criteria of familial pancreatic cancer. And this just shows you, it's an overwhelming slide, but the intention is to show you that actually half of the cases came from those known mutations, and half of them came from actually CHEK2. Now, CHEK2, this is more than what the general population should carry. This is actually weighted because Pittsburgh put in the majority of the patients, and we have a lot strong Eastern European heritage with the old steel mills that used to be the Eastern European. So CHEK2 runs about a couple percent in our population, but even with that, this is probably double what we would expect to see. It's too early to say. This is why you have to collect 300 patients, but whether this disease is another low or moderate penetrant gene that may put you at risk for pancreatic cancer. What I really need is my oncology, this is what I keep telling all my oncology colleagues, to find some treatment that would be a benefit for CHEK2, because that would make this very valuable if we could get yields that are over 10% on just doing a blood test when you're newly diagnosed, with being able to guide your therapy right off the top. So we had about 6% of our patients have those pathogenic variants, which was valuable for their treatment and for their family members. Only 4 of those patients met criteria for testing, and we found an additional 7 patients with CHEK2. So to summarize the talk today, the usefulness of genetic testing is not known outside of known hereditary syndromes associated with an increased pancreatic cancer risk. A lot of hereditary syndromes that I see for like my colon cancer group, we try to test anyone who has colon cancer under the age of 50. That doesn't hold for pancreatic cancer yet. There may be a gene, it's just not known, and the yield isn't that great, but that's something that we're looking at with this data set and others. We have to deal with limited guidelines. Some of the societies I know are starting to work on additional guidelines. I think that we may get to the role of genetics, and it was alluded to in the oncology talk and in my talk now. And what I could really foresee the future, if I had to put on, look in the crystal ball, is that a patient will come in, and at the time of their diagnosis, their tumor is going to be tested, and they're going to do germline testing as part of that to see what's acquired mutations and what were inherited mutations. And we'll have all this information to come up with a good personalized treatment plan for our patients. And keep in mind, surveillance is of unproven benefit, but it should be performed at centers performing research in it and trying to understand it. I know that's self-serving for me to say that. UCLA has a center that's studying it. We have a center. MD Anderson has a center that's studying it. So it seems like the experts are telling you send them to the expert centers. But unless we really can improve where we're at with surveillance, we're just doing tests without actually having any proven benefit. So I think it's very important. I couldn't do this without my group of surgeons and oncologists and GI docs that work together at UPMC, and so I just wanted to thank them. But I also want to thank all of the patients and their families for supporting our research program. It's always amazed me, and when we train our new coordinators, they're like, how can you come talk to these patients? Because we meet them, we're in the midst, because I'm interested in early detection, that they've been told that they may have pancreatic cancer. And we're asking them to fill out a questionnaire, donate some blood at such a vulnerable time. And I'm always amazed that over 85, 90% of our patients are willing to do that. And they realize that they're doing it because we're right up front with them saying, we're not sure if these findings will help you. It may help future generations. And that's enough motivation. So really, I applaud everyone for coming today and being educated. I'm sure many of you have participated in some sort of research program, but we cannot get to where we're at now. We're talking about improving 5-year survival rates to 10%, to 20% without everyone in this room. And I think that's important because we all have to be conscientious of the future generation. And that's my new little granddaughter, Savannah, to end the talk with. She's 3 months old. Thank you.